For joining us tonight. My name is James Relle. I will be your discussant tonight, and I am talking on a topic that is familiar to many of you, and that is prostates, enlargement of the prostate, and the symptoms that go along with it. My hope is at the end of today that you'll understand the mechanics of prostate enlargement and how it affects urinary symptoms and men's lives. And I hope that you'll have a better understanding on how to manage these symptoms and where to seek help. My education is, I'm an old guy. I've been around now over 30 years in practice. Did my bachelor's degree in the United States at Harvard University and completed my med school training, internship, residency, and fellowship at the University of Toronto, where I moved from 31 years ago and have been in the metropolitan Detroit area ever since. I specialize in prostate management as one of my areas of interest, and hope tonight to be able to give you a good education on that. What is BPH? BPH stands for benign prostatic hyperplasia. That's fancy doctor talk for a growing and big prostate. It's non-cancerous, it's completely treatable, and it's extremely common in the United States. In men in the age group of around 50% will have signs and evidence of an enlarging prostate. And by the time we're 80, men have an over 90% chance of having an enlarged prostate and the symptoms that go along with it. In order to understand BPH and how it causes symptoms, I have to take you on a little journey that involves some plumbing discussion and some weightlifting discussion. For those of you who are my patients, you've heard this discussion many times, but for those of you who aren't, and there's about 500 people enrolled in this discussion, I think you're going to learn quite a bit in a very short period of time. So think of the bladder as a weightlifter. Bladder is basically a bag of muscle, and it's designed to generate pressure by contraction. Contraction is the only thing that muscle is able to do. It gets shorter. So for a weightlifter, contraction results in generating pressure on a barbell and lifting it. If a weightlifter starts off in high school as a 98-pound weakling and he's getting sick and tired of being bullied and he wants to get stronger, he goes through a process called training. And what is training? Training is deliberately stressing the muscles so that they get bigger. Muscles getting bigger is actually a very unique characteristic of muscle tissue. The medical term is hypertrophy, but the regular talk is getting bigger muscles. And so a bodybuilder or a weightlifter will start off small and will gradually increase the weight on his barbell in order to generate hypertrophy or enlarging muscles. That's why weightlifters, in fact, get bigger. And this process will continue for years until the weightlifter gets as strong as he possibly can. So he will max out. Once you exceed this weight capacity, so let's say a weightlifter can lift 400 pounds as his maximum weight. If you put even one more pound on that barbell, what will happen is that he won't be able to complete his lift. He'll be able to lift the weight 90% of the way, but he won't be able to finish the task. So this is what happens when you max out a weightlifter. Now, if you think of what happens to your bladder, it goes through the same process. Think of it as a weightlifter, and think of resistance to flow as the weight on the barbell. So as we've talked about briefly earlier, the prostate, which is part of the tube through which we urinate, part of the pipe that the bladder drains out of, that gland grows with age. And because of its location, which is right at the start of the tube, it will obstruct the pipe and cause higher resistance to flow. As a result, the bladder will get stronger. It will hypertrophy just like a weightlifter. And it will continue to get stronger as the prostate continues to obstruct and add pressure or resistance to flow. The result of this is a very, very strong bladder. And this goes along completely asymptomatically until the bladder reaches its maximum strength. Now, here's where the problems start. When the bladder reaches the maximum strength, it now is maxed out and it can no longer do its task. Its task is to empty. And this is where you start to get symptoms: slowing of the stream, incomplete emptying, frequency, urgency, etc. If you look at the picture here, you see on the left the bladder, which is the big sort of balloon-looking thing with yellow urine at the bottom of it. And then you see what looks like a little bit of a funnel and a dark tube surrounded by a pink ball, which is the prostate. A much easier visual of this is think of a garden hose. When you think of a garden hose, you think of a rubber hose, but it's really more than that. At the very end of the rubber hose is a brass fixture, which is what gets screwed onto the spigot to connect the hose to the spigot. This brass fixture is actually part of the garden hose, and it's an important part of the garden hose, but it is made out of a different material, and water will flow through the center of it. Now, the garden hose in this example is the exact equivalent of your urethra. So your urethra has a long hose, which is what comes out of the penis, but at the beginning of that hose, the equivalent of the brass fixture is the prostate gland. So normally the prostate gland allows normal flow through it. But when it enlarges, think of what happens to, let's say, a floaty around a baby's arm as you inflate it. It will start to constrict inwards as well. And that's where the occlusion or obstruction occurs. And the picture on the right here depicts the enlarged prostate now compressing the inner cavity that the urine is supposed to flow through. So it's more resistance to flow. So that's your fluid dynamic explanation. And now we get the symptoms as a result of that obstruction. So urgency to urinate. This is a very annoying complaint. It's part of the irritative symptomatology that is caused by enlarged prostates. And the reason that patients get this is that your bladder, when it's overworked, is very, very thick and muscular, and it's very bad at stretching. It wants to contract, just like a bodybuilder is terrible at yoga. Bodybuilder can't stretch, can't do yoga because he's too muscly. Well, the same thing happens to your bladder. It gets too muscly, and it therefore doesn't want to stretch. So you have frequency and urgency because the bladder doesn't want to fill. You'll also have difficulty in starting your flow. This is because you have to build up tremendous pressure in order to overcome significant resistance. You'll have an interrupted or slow stream for obvious reasons. The flow isn't supported by the strength of the muscle. You have frequent urination because you don't empty properly. You have partial pushing painful pushing or straining to get the urine started. And you have the inability to empty the bladder completely because the bladder simply isn't strong enough. You also can get more significant and more health-threatening conditions like urinary tract infections, which is almost always the result of the bladder not emptying completely and bacteria growing in a perfect environment. Think of your sink that doesn't drain properly. It will have standing water that will get very grungy after a couple of days. Well, imagine urine staying stagnant for weeks on end because the bladder is not emptying. Same thing happens there. You can also, for the same reason, get bladder stones, which is crystallization of the products that come out in the urine. You can get kidney failure from the back pressure. Kidneys are in fact connected directly to the bladder through the ureters. You can get leakage or overflow incontinence, which is where you either can't get to the bathroom in time or your bladder is so full that any additional urine spills over, just like a overfilled coffee pot with more coffee being made. And then finally, you have permanent bladder damage that requires a catheter to drain it because the bladder no longer works. Now, an important characteristic of the benign prostatic enlargement is that it is entirely non-cancerous. There's actually zero correlation between the size of your prostate and your predisposition for getting cancer. They're independent variables. They both happen to occur in the same tissue, but they have nothing to do with each other. So BPH is benign. How do we diagnose it? Well, initially there's screening. We obviously get a full history and physical, which tends to support evidence that there is, in fact, an obstructive process going on. And then we do physical exam and some testing. The most basic exam is a digital rectal exam, where you can get an impression of the size of the prostate by feeling for it through a rectal examination. You can do a bladder scan, which is a non-invasive way of estimating how much urine is left behind after you're finished urinating. You can quantify the degree of symptoms with a symptom score index, and this is a reproducible questionnaire that those of you who come to our offices will experience, where there are 7 questions with scores going from 0 to 5, giving you a maximum or worst case scenario score of 35 out of 35 and a best case scenario of 0 out of 35. And we can quantify your symptom progression over time by using this questionnaire. We can also get an indirect assessment of the size of the prostate by PSA testing, because the more prostate tissue there is, the higher the PSA will be. And again, this has nothing to do with cancer. And then we can also do urine testing to look for crystals or evidence of infection. BPH can also be better described and diagnosed with some more advanced testing. One of the tests many of you may have had the pleasure of doing is a pressure flow study called the Eurocuff. Now, the value of the Eurocuff is huge. Even though it's not the most pleasant test, it is non-invasive, and it beats the heck out of the original test that we had for this, which involved a catheter placement through the penis, another catheter through the rectum, and then having you pee around those catheters and see how you did. That was a very hard sell. So the next iteration of this test was a non-invasive test called the Eurocuff, and it was called the Eurocuff because it replicated exactly what a blood pressure cuff did on the arm, except this time it was wrapped around your penis. Now that also became a hard sell because guys didn't like having a vice grip around their penis while they were trying to pee. So the company came up with an upgrade on how they measure the pressure. And now one urinates against a nozzle to generate a flow and a pressure reading. And these correlate very well with whether or not the bladder is overworked, obstructed, or damaged. So it's a very, very helpful test, just like blood pressure is very helpful in testing for the degree of stress that the heart is under. The more extreme testing is the urodynamics testing. That is also very helpful and selectively used in men. But it is the first test that I described in these 3 advanced tests, the one where the catheter goes in through the penis. It's useful in very selective situations to help decipher neurologic from obstructive, and probably a little bit advanced beyond the discussion today. But suffice it to say that some of you will end up needing this test. The final piece of the puzzle is advanced testing such as cystoscopy. Now, cystoscopy can be done typically in an office setting. It's done under topical anesthetic. It is, I would say, an unpleasant but not dreadful test. It will basically make you feel like you have a very, very strong urge to urinate that will last typically 2 to 3 seconds. I think the best analogy of a test that's similar is the COVID nose swab, which many of us have had, where they stick a thing in your nose and rub it around and it makes you feel like you're getting piffed. This is easier than that because we do use topical anesthetic, but it's a similar concept that it's momentarily unpleasant, but it does save you from needing a general anesthetic. It takes about 30 seconds to do from start to finish, and it gives us a definitive view of the pipe that you urinate through, the urethra, and the prostate gland, its shape, and how it's obstructing. So it's very, very helpful. It also diagnoses the condition of the bladder and looks for other surprises like bladder stones or tumors. Finally, a transrectal ultrasound is often used to give us a more definitive volume assessment of the prostate. The finger exam is useful, but very inaccurate. The prostate ultrasound is very accurate and is essentially a glorified finger exam. The probe is the same size as a finger. It lasts for a couple minutes longer because we need to execute images and measurements. The treatments are many, and they have evolved very nicely over time. Lifestyle changes don't really affect the flow dynamics, but they can affect your degree of lifestyle annoyances. So for instance, if you happen to be a coffee lover and you drink 3 cups of coffee every morning, or if you're a tea lover and you drink a pot of tea before you go to bed, if you're complaining to us about going frequently in the morning or that you're peeing all night, we would typically advise you to stop drinking 3 cups of coffee in the morning if it bothers you more than you enjoy your coffee, and stop drinking a pot of tea before you go to bed unless you love your tea more than you hate waking up 3 times a night. The next option for helping your symptoms are to avoid medication that will exacerbate your obstruction. The best example that I can think of is decongestants. So during allergy season, we often see a spike in patients complaining of urinary symptoms. Why does this happen? Well, allergy medicines often have decongestants, which tighten up the prostate. Medicines that tighten up the prostate add resistance to flow, and they will drive up symptoms. In addition to lifestyle and avoidance, there are actual medicines designed to help prostate-related obstruction. And then there's a whole bunch of procedures that we'll talk about in a moment to manage. So the lifestyle changes. As obvious, reduce fluid intake if volume-related frequency is your problem. If you're peeing 3 times a night, but you're peeing half a liter to a liter each time, that's a volume-related frequency. The bladder still has to empty when it's full. That's normal. So if you avoid getting it full very often, you'll have less frequency. Reduce your liquid intake and reduce the type of foods that will irritate your bladder to relieve some of the symptoms, typically frequency and urgency. So the big 6 are coffee, tea, soda pop and alcohol, spicy foods, and chocolate. Those are the big 6. They will typically exacerbate symptoms. None of those cause pathology. So that's a very important concept. You're not harming yourself by taking any of those. You're simply making your life a little bit more miserable by going more frequently and urgently. It's also very important to avoid constipation. Constipation is important because the colon and the rectum in particular and the bladder share the same nerve supply. So when your colon is distended, in the sense of constipated and retained stool, it will reflexly tone down or shut down your bladder, making it very difficult to urinate. So avoiding constipation is a key way to relieve some of the burden on your bladder. Medication is helpful to treat the prostate. The first thing are herbals. Herbal medicines can work, but know this, they are very, very, very poorly studied. Contrary to what the anecdotal testimonials will say, either online or in advertising, these products have never been definitively shown to actually do anything. That doesn't mean you shouldn't take them, but have realistic expectations. They may help. More likely than not, they won't do a fundamental difference for you, but it's worth trying. The second thing about nutraceuticals, vitamin supplements, and herbals is that very, very often, because they are unregulated, they do not contain what they say they contain. So you have to go with a company that has independent certification that tests for content and what's called bioavailability. If the company can't prove that the content on the label is actually in the pill and that stuff gets absorbed into your bloodstream, it's of absolutely no use to you, because essentially you're taking it in and you're pooping it out and it does you no good. Now, jumping to the real medicines that are proven to do work for the prostate, there are 2 classes. The alpha blockers, which are derived from blood pressure pills. These will relax the chokehold that the prostate tissue has on the urethra. So if you think of your windpipe, you can have trouble breathing for 2 reasons. Number 1, someone has their hands around your throat and they're choking you. That would be the equivalent of tightness, and the alpha blockers counteract that. The second problem can be that there's too much stuff in your windpipe. Let's say a piece of chicken got stuck there. Well, in order to shrink the prostate and get rid of some of the mechanical obstruction, you need an alpha block or an alpha reductase inhibitor. So the 5 alpha reductase inhibitors are Proscar and Avodart, finasteride and dutasteride. So the main class of medicines relax the prostate, the secondary medicines shrink the prostate, and sometimes we give both. Procedural options are likely to be recommended if one of 2 things happens. One of 3 things. Number 1, you don't tolerate the medicine. Lightheadedness, ejaculatory problems, ED. If you get any of those, most patients will not want to keep taking the medicine. Number 2, the medicine didn't help. And number 3, there's objective evidence that despite the fact that your symptoms are good, your bladder is actually being damaged and injured. So 80% of my patients come to me complaining of symptoms and wanting help. We'll either do medicines and or procedures. 20% of patients say, "Doc, I'm good. I don't need to be treated. I feel great." And I'll tell them, no, your testing shows that your bladder is damaged and is noticeably getting worse, and you need treatment. Otherwise, you'll end up with a catheter or kidney failure. So it's about an 80-20 ratio. Now, what are examples of procedures that will help the prostate once medicine has either been tried and failed or is unsuccessful in other ways? A minimally invasive option that has been popularized over the last 7 to 8 years is the Urolift system. What is Urolift? Urolift is a way of firing in essentially a staple or a stitch into the prostate that pins it open. So the prostate is a spongy tissue and can be compressed, very similar to foam rubber. Now imagine taking a piece of foam rubber and compressing it out of the way and then using a nail gun to keep it pinned down. That's essentially what the Urolift does. Between 4 and 6 little stitches are fired in through a side-firing device that is placed either in the office or under anesthetic in a surgery center typically. Each firing takes just a couple of seconds. The whole process of placing the Urolift takes, I would say, on average 10 minutes or less. 90% of the time, we do not have to leave a catheter after this procedure. Patients recover from symptomatic distress in the first couple of days, usually within anywhere from 2 to 10 days after the Urolift is implanted. And in the majority of cases, significant improvement in frequency, urgency, and flow rate are appreciated. It's a very effective, very slick, very interesting concept. I've had very good experience with it overall. I've probably done more Urolifts than anyone in the state of Michigan. I've done over 500 of them and continue to use it on selective patients. It has risks associated with it that are reasonable. It has benefits. It does have some downsides in that it doesn't quite replicate the efficacy of some of the more tested procedures. Rezum is a way of heating the prostate with actually very hot steam, which is about 70 degrees centigrade. Boiling point of water, of course, is 100. So it's very hot, immediate tissue death, which will cause resorption or shrinkage of tissue because you've essentially killed it. So what happens is we use topical anesthetic in an office setting. We enter the urethra with a specially designed telescope. There's a retractable fang that's hollow that gets popped into the prostate in selective locations. And at a 9-second interval, you steam the prostate by hitting a button, and steam gets forced in. The steam will kill a tissue circumference of about 1 to 2 centimeters. And if you strategically place this in several locations within the prostate, you can effectively shrink the prostate by killing it with this heat treatment. The benefits are that it is, again, there's no cutting. There's very low side effects, but you do typically have to have a catheter for as long as 5 days because there is immediate swelling. Imagine when you burn your finger on a stove, there'll be blistering and swelling initially, and then that will heal itself within a couple of days. But while you have that swelling, your urinary symptoms would actually get worse. So we routinely place a catheter preemptively when we do a Rezum procedure. But it is a slick, effective procedure. It also is somewhat compromised compared to, let's say, the TURP, which is the gold standard, which I'll talk about in a moment. But it does have its place in management of benign prostatic enlargement. Again, the immediate irritative symptoms are generally short-lived. It may hurt a little bit during the procedure, so we try to give you some medicine to calm that down. And rarely you get scarring after this, but I think it's overall quite a low-risk procedure compared to some of the others. The gold standard has always been the TURP, transurethral resection of the prostate, affectionately known as the Roto-Rooter. What we essentially do is, under anesthetic, we go in with a specially designed telescope that has a loop that looks much like a wire cheese slicer, and we shave away at the tissue that is plugging up the central channel of that think of it again as the brass fixture that starts the garden hose. So when we open up that brass fixture, you now have reconstituted the nice wide piping that is the same as the rest of the urethra. This procedure is highly, highly effective. It's highly, highly predictable, and it's generally quite uncomplicated. The biggest complication that you can get typically is transient bleeding. And so for that reason, we typically admit patients to hospital overnight for observation, and we typically recommend a catheter for 2 to 3 days after to rest the bladder and reduce the chance of an immediate bleed. I would say that the success rate with the TURP is about 98%. It's a very, very predictable procedure, but it is not new and therefore not sexy, and therefore other tools are more easily marketed, and consequently you hear about the other options much more frequently as being better or less invasive. That may or may not be true. I'll be quite honest with you. I have resorted to TURP very, very often. It is still probably my most preferred treatment for benign prostatic enlargement. Green light is essentially a TURP, except using a different tool. It uses green light laser energy. It uses thermal energy essentially to vaporize tissue. It is essentially doing exactly what a TURP does with a different energy source. There is, I would say, a higher side effect rate than with a traditional TURP. Typically, more frequency and urgency is a side effect after the laser treatment, and a higher incidence of scarring in the healing process. Optilume is a very, very interesting new treatment. The word is not yet out on its durability, but conceptually, what this does is it dilates, super dilates your prostatic urethra with the balloon, and the balloon is coated with a drug that resists new prostatic growth. So it's a very interesting concept. We have a similar treatment modality for scars that happen in the urethra, and the chemical coating will inhibit scar formation and regrowth of tissue, and so it will improve urinary symptoms immediately with a good predictability. What I think is in question, and it's not yet time tested to give the full word on this, is the durability. Aquablation has been popularized by a very, very effective ad campaign by the company that makes the Aquablate technology. This is also a version of a TURP, except instead of using laser energy or electrical energy, this uses a high-powered water cannon. So if you know anything about the steel industry or basically any kind of cutting tools used in industrial cutting, water pressure or a fine water stream under very, very high pressure is a remarkably effective cutting tool. You can use that technology to blow apart, vaporize the prostate by blowing apart cells under very high pressure with a very controlled stream of thin, high-pressured water. And if you think of it like a windshield wiper, this high-pressure water will sweep in a predictable pattern that you map out by ultrasound technology and will core out the prostate. It's effective, and I've used it for the purpose of what I call debulking the prostates. Rather than doing an open surgery on a patient with a very, very large prostate, I'll use this technology because it's quite fast to open up the central channel of a large prostate, large being 3 to 4 times a normally enlarged prostate, so an outlier. And then because this technology has no way of stopping bleeding, the terminology is hemostasis, it doesn't stop bleeding at all. You routinely have to then go in immediately after you do the Aquablate with a traditional TURP instrument and cauterize and shave away any of the bleeding tissue. So this is a debulking technology rather than an alternative to a TURP. I think the company would like to sell it as a TURP replacement, but in all honesty, that is not the case. But nonetheless, it is an effective treatment, and it's on the list because it does work. Prostatectomy. This is the old-fashioned way of removing the prostate. We make an incision in the lower part of the belly, we open up the bladder and the prostate, and we core out the prostate with our finger in a very similar technique as taking a grapefruit and separating the pulp from the surrounding rind. This can be done either open or with a robot. In any case, the surgery is the same. What's different is the size of the incision. But fundamentally, it's removing the part of the prostate that has grown and is now blocking the urethra. The most recent, newest, and for sure sexiest, and by far least invasive technology that's around is called PAE, prostatic arterial embolization. To summarize how big a breakthrough this is, imagine 30 years ago if you had a blocked heart vessel. If you had a blocked heart vessel, the treatment for that was a coronary artery bypass graft. So a cardiac surgeon would crack your chest, take a vein from your thigh, and take that vein and bypass the blocked artery. That operation would take a week to 2 weeks in hospital to recover from, another 6 or so months to recover fully from the cut through the sternum and to resume full activity. It was a long, very successful procedure, but a long process in recovery. The cardiologist said, oh, we can do better than that. And what they do is they go in through your wrist or through your groin, and they also, with a small catheter, get to the blocked vessel. But what they do, instead of bypassing it, is they put a balloon through it and dilate it open. And then they splint it open with a stent. And so rather than having 2 weeks in hospital and a 6-month recovery, it's 45 minutes in hospital and you go play pickleball the next day with an open artery. So that was a huge advance by doing minimally invasive vascular treatment. PAE is the analogy of that with regards to the prostate. As we've talked about, benign prostatic hyperplasia, growth of the prostate, is the root cause of the obstruction. So by shrinking the prostate, you would undo that resistance to flow and undo the damage. Well, PAE is a way of shrinking the prostate. And the way that it's done is we go in the same way the cardiologist would go in, through the groin typically, but also eventually probably through the wrist, and go through the vascular tree until you get to the artery that feeds the prostate. These arteries are tiny, and I have a video here which we'll start in a second to show you what's done. But we block the artery. So unlike the cardiologist who will widen the artery to open it up, we will do the opposite and plug it up. So if we could get this rolling, give me a second here. Our technicians will share the video with you. The catheter goes in through the artery. With fluoroscopy or X-ray guidance, they will snake their way down to the very small little arteries feeding the prostate and plug them up, which will result in shrinking the prostate. They go to the other side, repeat the process. There's 2 arteries, one on each side feeding the prostate. There's a catheter going in. Now the catheter sends a chemical in, tiny little beads to plug up the artery. The prostate shrinks away. So if we could have the slides back. The PAE has been highly successful. We are very fortunate at MIU to have an exceptionally talented interventional radiologist who's probably done more or almost as many as anyone in the country. Our experience was that the radiologists who were doing this, who were excellent interventional radiologists, were taking on average about 3 hours to do the procedure. Our team can do it in about an hour. They are reliably doing 4 a day in our office, and patients have been exceptionally happy with the results for the most part. Generally, the procedure takes, let's say on average, an hour to do. It's done under very light sedation. You lie flat on a bed to recover for about 2 hours so that the groin stick where the needle goes in doesn't bleed. The first week, the side effects are generally quite minimal. There's some very temporary worsening of the irritative symptoms because of some swelling that happens. Whenever you treat tissue, there's a little bit of reactive change. So there's some irritative symptoms that develop. Medicines will typically counteract this successfully and quickly. And the success rate in shrinking the prostate and achieving significant improvement in flow and reduction in symptoms is in the range of about 90%. And considering that this is a non-surgical, non-cutting procedure, it's an excellent, excellent alternative, and certainly one that we often start the process with because it doesn't preclude later on doing more advanced or more invasive procedures if this wasn't satisfactory or if it fails over time. So I hope this was an effective overview for you. Talked about the pathology, what actually happens and why you get the symptoms. We've talked about how to manage them and how to treat them and some of the side effects associated with that. So what I'm going to do is I'm going to answer some of the questions that were asked earlier. I do want to acknowledge that these questions are going to be very generic, and we're not able to answer specific questions about your individual condition or your individual scenario or experience. There's over 500 people on this call. If everybody were to talk about their experience with this, that, or the other, it obviously wouldn't be a sustainable conversation. But the questions that I'm going to answer really focus on general principles that I think will help you. So one of the questions is green light analogous to HoLEP? So HoLEP is a version of laser treatment, which is a very, very interesting way of doing a simple prostatectomy. We talked about open prostatectomy that can be done with either open surgery or a robot. This is an extension of that, except done through the penis, again under anesthetic, using a laser to essentially cut away or differentiate the rind of the prostate, which is not what's grown, versus the pulp of the prostate, which is what has grown. And so the HoLEP cuts in that space between the two and allows us to pop out the sort of ball of prostatic tissue that's obstructing, as opposed to the green light or other laser forms, which vaporize tissue by direct contact or close contact. So they're fundamentally different, but they achieve hopefully the same thing. If patients have a kidney disorder, is it important to get your prostate treated? So my answer to getting the prostate treated is your prostate should always be treated if it poses a fundamental risk to your kidney health by back pressure on the kidney. So again, the specific testing that we talked about will shed light on the fact of whether or not your prostate is causing a high pressure bladder scenario. And if the pressure is very high, you have to understand that your kidneys are fighting against that pressure to get the urine into the bladder. So the answer is, if you have kidney failure, kidney damage, or reduced kidney function, you're better off having your obstructive urinary symptoms treated. Are there exercises to help control? The answer to this question is, if you ask this question, you haven't quite grasped the fundamental problem. The fundamental problem here is not that your control valve is deficient. The fundamental problem is that your bladder is overworking, and it's overworking because it has had to fight through too much resistance. Again, the analogy that I can best describe this with as a visual is, think of a bodybuilder walking down the street. He does not dangle his arms and walk in a relaxed way. He walks down the street like this because his muscles can't stretch. And similarly, if he tries to go into a yoga class, he can't touch his toes because his muscles fight back and they want to contract. When you're having urgency, frequency, and incontinence, it's because your bladder is a bodybuilder, and it's a bodybuilder because it's fighting against too much resistance. None of the exercises in the world will relieve the resistance. That's the treatment. And similarly, I might add, drugs to suppress your overactive bladder are actually probably doing more harm than good because they're fundamentally not addressing the problem. So here's a great example of treating a symptom and not the problem. If someone comes into my office and says, "Doctor, I have the worst headache I've ever had in my life. It's a terrible headache. And every time I bend my neck, the headache gets 100 times worse." I can tell him, "You have a headache. Take some aspirin. It'll make the headache feel better." Or I can say, "You got to go to the emergency room and treat that bleeding aneurysm, because that's what's giving you the headache. When you treat overactive bladder with a medicine to suppress your bladder, you're treating the headache. You're not treating the brain bleed. So go get your prostate checked, make sure it's not obstructing, and then when all the resistance is relieved, if you still have symptoms of an overactive bladder, then you can start taking medicines to suppress the bladder function. One of the questions is coffee, soda, and alcohol was mentioned, but how does the water intake affect urination? Well, very simple. What goes in must come out. Simple as that. If you have a high PSA, why do you have to delay taking action on BPH? Well, that's a great question. PSA stands for prostate specific antigen. It is the product of the prostate gland, just like saliva is the product of the salivary glands. Prostate glands have two changes that occur with age that are very common. Benign prostatic enlargement, BPH. 90% of guys get that. Prostate cancer, 10% of guys get that. So one is very common, one is common. Both entities, prostate cancer cells and benign prostate cells, both produce PSA. Cancer, by virtue of the fact that it's growing faster, will produce more PSA. So when you have an elevated PSA, it can be because you have a big prostate, or because you have a cancer, or both. And until we know what you got, we have to test, and that's why it might delay your treatment. So we're not delaying your treatment because we feel like we want to be mean. It's we want to make sure you don't have cancer, because that's treated entirely differently. And again, remember, PSA doesn't tell you that you have cancer. It just means that we have to explain why it is what it is. And there's, again, no correlation between having a big prostate and a big PSA from that and being at risk for cancer. So a lot of patients feel that they need to get their PSA down. What can I do to get my PSA down? Well, there's zero value in getting your PSA down. PSA in and of itself is not dangerous. It's not like having high blood sugar, which is dangerous, or having high cholesterol, which is dangerous. High PSA isn't dangerous. The PSA doesn't harm you. It's just we need to know, why is the PSA what it is? Complications of a TURP we talked about is bleeding, scarring. Those would be by far and away the two biggest. Incontinence, very low risk, under 1%. Erectile dysfunction, under 5%, typically closer to under 1%. What does happen as a, not complication, but a effect of the TURP is that men will have vastly reduced, if not absent, ejaculate fluid. So that is one thing that will change after a TURP, and actually after almost all of the prostate procedures, not all, but almost all, which is that you will lose your volume of ejaculation. That doesn't seem to happen with the PAE. It doesn't seem to happen with the Urolift. It can happen with the Rezum, but doesn't happen all that often. It will maybe happen with the Aquablate, but it's not uncommon with that. It will happen with the TURP, and it happens with the slightly different variant of a prostate procedure called the TURP, which is sort of beyond the discussion of today's procedure or today's discussion, but you can get 10% incidence of retrograde ejaculation with that. Is PAE better than Aquablation, or is it patient-specific? So PAE is entirely different, as we talked about, in terms of what it does. It shrinks the prostate. Aquablate actually eliminates prostate tissue, as again does a TURP. So again, think of Aquablate and TURP as one thing, and PAE as the other. So we get a very high satisfaction rate and very high improvement rate with PAE. So in the select patient who is a good candidate, meaning we factor in all of our testing, your flow rates, your pressure of your flow, the size of your prostate, the shape of your prostate, what else is anatomically there, and we decide, is this patient a good candidate for a PAE? Because if they are, we often will default to that as the first line of attack, because it is the least invasive and the least complicated. So why not try something that has a 90% success rate and a low side effect rate, rather than jumping to a more invasive procedure right off the bat? It doesn't mean that Aquablate or TURP isn't the better procedure or even the more appropriate procedure, but that's the line of thinking. If you have something that works well and is low risk versus something that works very well and has slightly more risk, that's where the decision-making comes in. So that's worth your discussion with your urologist. The lifespan of Rezum, and quite honestly, of many of these minimally invasive prostate procedures, is highly dependent on a variety of factors. So I can tell you this as a categorical statement. Rezum's durability is less than a TURP's. And the reason it's less than a TURP is because you're not eliminating nearly as much tissue as you do with a TURP. So I think that's the best way to answer that. Next question is, will a suprapubic catheter damage my bladder? The answer is no. A suprapubic tube will actually save your bladder, as will a regular catheter. A suprapubic catheter is much more comfortable than a catheter going through the penis. So for long-term drainage, a suprapubic tube is the way to go. And it's a much more pleasant alternative, I would say, than intermittent self-catheterization, which is the third option in the equation, which would mean you catheterize yourself every 3 to 4 hours to drain your bladder. So no, a suprapubic tube is actually a very important piece of the puzzle to help patients whose bladder is permanently damaged or temporarily has to be catheterized until they can have a definitive procedure. Does PAE completely block the artery or just restrict the blood flow? It's designed to selectively block the isolated vessel that they're targeting. Completely block it, plug it up. Does PAE help ED? It does not. It does nothing for ED because we're not plugging up or opening, for that matter, any of the arteries that have anything to do with the penis. Another question, can you take ED medications after both PAE and aquablation procedures? Absolutely. There is no correlation between the danger, benefit, risk of ED medicines, whether you've had or not had any prostate treatment. They're independent, unrelated processes. Although interestingly, some patients find reduction of urinary frequency with a low dose daily use of Cialis. I don't think it fundamentally affects any of the flow dynamics, but it can improve that one symptom. The risk of ED and ejaculatory dysfunction with regards to these procedures. So I think I touched on that earlier, but the more invasive a procedure is, the more likely it is to cause low volume ejaculation or no volume ejaculation. ED is a different issue, and I would say is unlikely to occur with any of our traditional prostate procedures, with the exception of a radical prostatectomy, which is not today's discussion at all, which is used for prostate cancer treatment. Does shrinking the prostate reduce PSA readings? Absolutely. The more prostate you have, the more your PSA is going to be. The less prostate you have, the less PSA. Do any of these procedures reduce the incidence of urethritis? I would say no. Urethritis is inflammation of the urethra. That is typically only caused by, or most commonly caused by, sexually transmitted conditions. If you have recurring infections, again, there are multiple reasons for this, and you should look to have an explanation because they're not normal in men to have urinary tract infections, and there's always an explanation. Will the transrectal ultrasound differentiate between an enlarged healthy prostate and cancerous tissue? And the answer to that is it can. It doesn't mean that it always will, but it is a reliable indicator of several things. The size of the prostate, looking for abnormal tissue within the prostate, correlating that to the digital rectal exam, and looking at a concept called PSA density, which is the amount of prostate tissue compared to the amount of PSA. The general rule of thumb is a 10-to-1 ratio. For every 10 cubic centimeters of benign prostate tissue, your PSA reading will typically be about 1. So if you have a 30 cc prostate, your PSA will be 3, 50 cc prostate, PSA of 5, etc. Is there anyone who's not a candidate for a PAE? Absolutely. If your prostate is not of an adequate size, meaning your prostate's actually small, it can still be very obstructive and small, just so you know. But if it's very small, you're not a candidate for a PAE. There are certain other conditions that may be more closely related to a patient's anatomy, meaning the vasculature that's discovered there, and other factors. These are things that the radiologist, whenever anyone in our office is advised to consider a PAE, we always set them up with a consult with our interventional radiologist. They are experts in this procedure. They have their own numbers for risks, their benefits, their success rate, their outcomes, and you know exactly what you're getting because they're going to give you the statistics in their hands. They will also tell you if you, based on all the information we've generated for them, are in fact a good candidate for the PAE. All right, final question. What is a normal PSA level? The answer to that is there's no such thing. So PSA is part of the evaluation of your risk for prostate cancer. The only reason we do PSA is to help early detection for prostate cancer. Before 1989, so when I was a medical student and an intern, there was no early warning system for prostate cancer. We detected prostate cancer the majority of the time when a patient had spread disease, metastatic disease, stage 4, where it had gone into their bones or lymph nodes and caused problems. You could detect prostate cancer by digital rectal exam, but by then it was typically a very big nodule. So prostate cancer was typically diagnosed late, and as a result, it was the #1 cancer killer in men. When PSA was discovered, we went on a PSA spree. Every single person in the world who was a guy over the age of 40 got a PSA done. We'd have booths set up at ball games, at fairs, at health events. Know your PSA, check your number, ad campaigns, huge ad campaigns. And so everybody got their PSA checked. And when you have a blood test, you need to have an upper limit of normal and react when it's above that and pat a patient on the shoulder and say, don't worry. Now, that's a very arbitrary number. So what they basically do is they take 1 million people and they look at where is the 95% cutoff point. And they'll say, okay, if you have a PSA of over 4, that means you might have prostate cancer. Well, what that means is that the guy who has got a PSA of 3.9 is patted on the back and say, don't worry about it. And the guy who has 4.1, it's doom and gloom. And that's, of course, total nonsense. So what's evolved over time is that we take everything into context. So if you have a tiny, tiny prostate and a PSA of 3.9, that worries me. If you have a PSA that has been 0.5, 0.5, 0.5, 0.52, even though the PSA of 2 is entirely normal, that change, that quadrupling of your PSA, that scares me. So these are the things about PSA that are nuanced and that have to be taken into account. Similarly, I have countless patients who have PSA of 20. Well, they have no prostate cancer. They just have jumbo prostates. So there's no such thing as a normal PSA. It's a question of what is it, why is it what it is, and then what happens to it in the future. And that's what tells us whether or not you have a risk of cancer. And then we look for it if we think you do. And if we think that you have a low risk of cancer, we continue to follow you. Thank you all for participating. We went under an hour, so yay for me. I hope this was useful. If you want any additional information, I suggest you contact one of the many very qualified MIU urologists. I'm available also for consultation. You can check our websites, and we'll be more than happy to help you. I hope you found this interesting, and thank you again for your attentiveness. Have a good night.